who are going to discuss on the rational use of antibiotics in OPD, in the hospital ICU, and the stewardship, components of the stewardship program, basically how to go about the management. So I would request our trustee, Dr. Jayesh Lele, Honorary Secretary General, who has been instrumental in getting this webinar series at our branch. I welcome him. I wish him a very happy birthday on behalf of the entire IMA Mumbai West and entire IMA. Please, sir, welcome you.
Thank you, Dr. Saurabh. As mentioned, this antimicrobial resistance is a growing menace, and last 3 to 4 years, IMA has been arranging at various levels. Even last year, we had a national program. So this year, we changed the program theme. At the same time, we changed the concept and how to go about it. So far, we have already had in 12 states the program. Two central programs, one we had last week in Delhi, and now this is another central program where we had a hybrid program, and the doctors across India will be joining, and subsequently the same will be uploaded onto our website. GSK has been helping us to arrange this antimicrobial resistance series programs last couple of years. And definitely the justice will be done in today's program also. As Dr. Saurabh has mentioned, the topics are very interesting. Some of the states we have already booked, and within another 3-4 days time, all the programs will be completed. I will invite our National President, Dr. Jayalal sir, to give his presidential address for this program. Over to National President, Dr. Jayalal sir. Gautam, unmute. Yeah,
Yeah.
please.
Distinguished leaders of Indian Medical Association, our beloved Honorable Secretary General, Dr. Jayesh Lele, the very enthusiastic and very dynamic and the role model branch of Indian Medical Association. And I am a Mumbai West branch and the leaders of Mumbai West branch. Exemplary workforce of this Mumbai West and the other leaders of Indian Medical Association. I'm extremely happy to be with you at this moment through online. One of the notorious and very useful and fruitful event which Indian Medical Association is organizing with a great concern and responsibility on the antimicrobial resistance which is mounting in our country day to day. I know for sure that because of the abuse of the antibiotics and abuse of the drugs, and we do not have a system of the regulation of this, and so much of drugs are being sold on the OTC, and every day we are now getting cases of antibiotic resistance, and where our hands are tied, and we have seen many people are dying in front of our own eyes with a small, simple infections like malaria, pneumonia, where we are having that bacteria and virus which is much resistant. And we know for sure with the tuberculosis where we are getting nearly 14% of the case are now in antimicrobial resistance stage. But unfortunately, in the last few decades, the newer drugs which we are getting is very few. Even the drugs on the pipeline low. We have only one or two drug has come. It's a resort for the newer antibiotic resistance. And now many bacteria, because of that is quacks are using in animal husbandry, they are using in apiary, they are using in every part of the things. That is, an antibiotics are used widely without any dose, without any control. So that is resulting in that the precious drugs are being unused. One of the very common thing we always advise to our practitioners is using the fluoroquinolones, especially the ciprofloxacin, which is used as a second line for a tuberculosis. So when you are using it for an protein common infections, for the respiratory tract infection, that is going to be resulting in a resistance. But very recently we did a study where we have done a prescription study of a practitioners, our own modern medical practitioners for an LRI and URI. And we are able to surprise to see nearly 75% of them has prescribed a fluoroquinolones for that. Though there is Indian Medical Association, all the organizations are very insistently saying do not use antibiotic. Whether the patient comes for the viral disease like diarrhea, still we are seeing a lot of antibiotics, and now that has become a passion to write higher antibiotics also. Another, we did it will be on the medical students when the CRRI or interns, when they are coming, straight away they are going for the third generation cephalosporin without trying the normal drugs which are available. So that is all mounting up to the antibiotic resistance. So WHO also feels that it is very important that we should talk on that issue. Indian Medical Association is very much interested on that issue. That is why the last few weeks and we are organizing this program. And we all know on the coming 17, this an antibiotic resistance day is being observed. So IMA is also resolved to do that program. So that is one of the thing is blue light campaign is one of the concern of the antibiotics, drug resistant. So probably HSG will be sending you a letter very shortly that this week in commemoration of this antibiotic resistance week, we will be requesting all of you to put some blue light campaign so that we will be first of all we should make our house in order. We will see to that our own people are not writing much of unnecessarily antibiotic, and they are controlling the antibiotic with an evidence-based antibiotic practice, especially in the post-operative period. And so much of studies and so much of evidence available, the single antibiotic dose or the prophylactic antibiotic is good enough instead of using for the 7-8 days of antibiotic. So that is been very practically used. So all these awareness the IMA has to do. That is the reason why that we are organizing this program. Equally, we have to fight with the government of India for curtailing and curfewing the non-medical, non-modern medical people practicing antibiotics of modern medicine. That is also rampant. We did a study where it says nearly 40% of the prescription of the antibiotics by the non-allopathic doctors. So that is also a major problem. And we also now recently we read a report that the honey which we are preparing or the even the normal products which we are getting from the fruits, and many industries are adding antibiotics into that so that they will be preserving it from pesticides and other like things. So that is also going to be a resultant in a role. So all this awareness we need to create, and we have to work together. So I must take this opportunity to congratulate GSK for coming forward and supporting this educational work of Indian Medical Association. I'm thankful to our Honorary Secretary General, Dr. Jay Srile, for formulating this study program, formulating this entire concept, and taking up in a very short period. And he has completed both online and hybrid programs. So my hearty congratulations to Jay Srile for his exemplary work he is doing. So I must also thank once again Mumbai West for doing this program as a hybrid program and making it is one of the most important and much awaited program. And I'm happy to see more than 275 people have joined through the online also. So that is also one of the very highest number of people who is able to enroll through the virtual. And this program will be available on our website so that many more people can see this program. So, and from the headquarters, we thank you once again and wish you all the best for this very, very social responsible project of Indian Medical Association on antimicrobial resistance. Thank you very much.
Thank you, National President, sir, for your very nice, kind words and appreciating IMA Mumbai West. We will continue this program. Today's program, there are three main speakers. The plan I am going to explain. One is antibiotics used in the OPD. That is, day in and out we use this antibiotics. That will be taken by none other than Dr. Ketan Mehta, who is a consulting physician, diabetologist, and he is also the chairman of our antimicrobial resistance committee, standing committee for the IMA National. Second topics will be taken by Dr. Agam Vora, is a chest physician, and he will be talking on antibiotics used in hospital and ICU practice. And at the end, Dr. Mangesh Tiwaskar, another consulting physician, diabetologist from our branch, he will be talking on the program, stewardship program, how to go about it and what steps to take it further. So, without wasting time, I will invite Dr. Ketan Mehta, our own person who is looking after all the educational activities, to start his lecture, and he will be giving a few final tips. And at the end, all the question answers will be taken, or discussion, panel discussion will be taken. It will be moderated by Dr. Krunal from GSK. Thank you. Thank you. Over to Dr. Ketan.
HST, let me congratulate Ketan and Agam Vora for their exemplary contribution they are doing to IMA. I think they are very tall people in the API but now you are taking the shine out of them and you are utilizing them for IMA. It is a great boon for Indian Medical Association. Both Ketan and Agam are with us now. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir. Uh, Very good afternoon to one and all. Dear friends, it is indeed an honor to be present at your own branch and standing physically. We have done a number of webinars. In fact, the designation which were given to us, like we have become a webinarologist. But now to come physically over here, it's indeed an honor. And that also in a very important topic, what we are going to talk and discuss in this antimicrobial resistance. Friends, as all of you know, from 18th November to 24th November, it is celebrated globally as AMR or Antimicrobial Resistance Awareness Week. And in this, we are going to have a series of talks in this. What we have planned, I would be talking on the aspect of, that would be talking on the usage of antibiotics in OPD practice. So I will start my presentation. One sec. Okay. So friends, what I am going to talk is the rational use of antibiotics in outpatient settings. I'm sure you as a family physician are seeing day in and day out the large number of patients, and in which it is very important where to use, what to use, how to use, when not to use. These are all important aspects of antibiotics. Friends, we remember when the antibiotics were started discovering, and we had the first one, the penicillin, which were discovered, and that was the time when World War II was going on. And we realized it was thanks to penicillin, which the medical fraternity realized, oh, now we had a hopes in fighting the infection, and that was so much hope for it. But what has happened over a period of time, the antibiotics, which has been not just used but has been misused. Now what are antibiotics? All of you know it is like destroying or inhibiting the growth of bacteria by either selectively killing or inhibiting the development of disease. Most commonly prescribed drug in the hospital setting also is antibiotics also. But what has happened? The lack of strict regulation and irrational use had led to this increasing drug resistance, which we are seeing day in and day out, which leads to the disease length, health complications and adverse effect also. And that is why it is very much pertinent that we use rationally antibiotics in our day-to-day practice. So here I would like you to go through this very important message about the life, which takes one full circle. So let's look at the history of medicine. In 2000 BC, whenever some infection used to be there, what was the solution? There was a here, eat this root. In 1000 AD, it was like that root is heathen, so here say this prayer. In 1850 AD, that prayer is superstition, so here drink this potion. In 1920 AD, that potion is snake oil, so here we have a pill, so swallow that pill. In 1945 AD, that pill is ineffective, so here take this penicillin, because now we have got some powerful weapon. In 1955 AD, what happens? Oops, the bugs mutated, and here take the tetracycline because your previous drug is not acting. And in 1960 to next 4 decades, there were another so many oops, and you need to go on taking more and more powerful antibiotics. And what happened in the beginning of 21st century? Oh, the bugs have won, so here eat this root. And that's how, all this supplementing Ayurveda and all this coming forward and giving what not and what is there. So friends, remember one thing, what we receive is information, what we preserve is knowledge, what we use is intelligence, but what, when and how we use it is our wisdom. And that is where it is very important we as a clinician must use our wisdom so that we can prevent these cases of antimicrobial resistance. So I'm going to give you a certain case scenarios. So this is the first case, a 21-year-old female weighing 70 kg, history of coryza and body ache for 2 days, history of low grade fever for 1 day, contacted family doctor, started on azithromycin 250 milligram once a day given for 3 days. No much response. On day 4, she contacted doctor again. So who started in on, okay, now you change the antibiotic, take this cefuroxime 250 milligram twice daily. And what happened? Patient improved in next 3 days. What is the moral of the story? This was a very classical viral fever. And if he would have not given antibiotics, anyway the patient would have recovered in 7 days. But giving antibiotic, what happened? Patient recovered just in 1 week's time. So not giving antibiotics 7 days, giving antibiotic just 1 week. Is there a logic in using that? Let's look at another case scenario. This is a 64-year-old male, diabetic hypertensive since 6 years, had a history of recurrent renal calculi with urinary tract infection. We know that urolithiasis are prone for urinary tract infection. Now again presented with dysuria and high-grade fever with chills since 2 days. Now, this was the current COVID time. So, you know what is the current trend? Everybody who presents with fever, the first diagnosis is COVID, and COVID unless proven otherwise. So, similarly, family physician started him on doxycycline 100 milligram BD, where they thought doxy would be a better option because it has now the usage has increased in the COVID time. Now, what happened over here? There was no response symptomatically. Urine routine showed 60 to 70 pus cells. WBC count had gone up to 14,500. Symptoms persistent. So the family physicians thought, no, I think let's make changes. So doxy was continued, but he said, let me add another antibiotic. So he added amikacin, 500 milligram intramuscular OD. Patient developed oliguria in next 2 days and required to be hospitalized. Why? Because it was an obstructive uropathy with acute kidney injury due to the amikacin. Now, you know, the trend of giving injectable antibiotics in family practice has also increased. Is it really justified? You really need to take a call. And that where it is going to make a selection for the patients very important. So this reminds me of a quote from William Osler, who is considered as the father of modern medicine, that one of the first duties of the physician is to educate the masses not to take medicine. Now you will be wondering, he is the father of modern medicine and why he making such statement. And he clarified that the person who takes medicine must recover twice, once from the disease and once from the medicine. And that is so much true. We talk of any therapeutic segment. So definitely even for antibiotic segment also. So why we are talking so much about this irrational use of antibiotics? Because this problem is not in India, but it's a worldwide global problem. In fact, 85 to 95% of all antibiotics for humans are prescribed in outpatient settings. So it's a very important chunk. Out of all antibiotic prescription, almost 90% is used in outpatient settings. And 50% of the patients fail to take them correctly. Now that is also a very important point, because even if it has been prescribed correctly, it is at the patient level where there is a problem which comes. And above all, we know that 1/3 of the world's population lacks access to essential medicines. So most irrational use of antibiotics in outpatient facilities occurs when antibiotics are prescribed for viral respiratory tract infections such as viral bronchitis, otitis and sinusitis, where it is absolutely not required. That is one thing is there. You should be confident enough in telling your patients, no, you don't require antibiotics also. Now, when we talk about AMR, what is exactly AMR? Antimicrobial resistance is the ability of the microorganisms that cause disease to withstand the attack by antimicrobial medicines. So AMR is rapidly becoming a major public health risk and is threatening to undo decades of advancing in treating disease. We have seen it takes years to get into good therapy of a particular segment, and such antimicrobial resistance is going to cause absolutely reversal of this development what has happened. So the impact of this, there could be an increased morbidity and mortality, wastage of resources. Our country, which is, we are talking about resource limited setting, and we need to be careful when we are looking or selecting a particular drugs. And it will lead to increased risk of adverse reactions and emergence of antimicrobial drug resistance. Now, if you look at the data, now according to the CDC, that is Centers for Disease Control and Prevention, irrational prescribing of antibiotics to outpatient settings will be the primary drivers of resistance pattern and will be responsible for almost 2 million deaths each year. Now that's a huge number. We are worried about looking at the corona deaths, which is also a huge. Now here we look at something preventable, and that is where we are worried about. And what are the commonest drugs which are being misused? And that, if we look at the statistics, it is the penicillin, macrolides and cephalosporins. These are the three most prescribed antibiotic classes in outpatient settings and where it would have definitely an impact. Now, if you look at this tabular chart presentation, if you see the non-prescription use of individual antibiotics for upper respiratory tract infections. So, if you see that these are the drugs which are being sold over the counter, have been used by the patient by themselves without the prescription of the doctor, and amongst them amoxicillin and co-amoxiclavulinic acid are the commonest one. Almost 1/3 of prescription, 1/3 of those consumption is due to this. The other commonly used drugs are roxithromycin, azithromycin, ciprofloxacin, cefixime and even levofloxacin. So these are the drugs which have been used by patients themselves without even a prescription also. Now let's look at if you talk about the global scenario, the countries consuming most antibiotics overall in 2010, India was 13 billion standard unit and United States was 7 billion standard units. However, if you really talk of the per capita consumption, India has got a much larger population. So obviously India is really leading if we talk of per capita consumption, much higher in that. So now let's look at this chart. This chart has very nicely shown the development of resistance to newly introduced antibacterial agents. And you will be surprised, whenever drug is discovered, it takes few years to come into the market because obviously there are various phase 2, phase 3 and phase 4 clinical trials which are going on it, and once it is approved, there is a FDA approval will take a little longer time. So even when the drug was discovered, by the time drug gets approved by FDA, still there is a margin. And look at this table. Now if you see penicillin got approval in 1943, though it was discovered much earlier, but when was the first reported resistance was in 1940. And similarly, if you look at the latest one, the linezolid, which was approved in 2000 by FDA, and the first resistance was reported in 1999. So where are we heading? Before even it gets approval, there has been cases of resistance which has been observed over there. So let's understand the drivers of this irrational antibiotic prescription in outpatient care. One is the clinician prescribing antibiotic before the test results confirming a bacterial infection. So a clinician is not sure whether it's a bacterial, viral, fungal, or whether it is really an infective fever, and without that prescribes antibiotics. Second, patient pressure to receive an antibiotic. That is also common. Sometimes patient will come and ask you, hey doc, do I really need antibiotic, or do you want to start because I'm traveling day after? So the patients have become too much demanding, we know that. patients are taking antibiotics by themselves. They remember, oh, last time my doctor had given me so and so antibiotic for this symptom. Now I have the same symptom. They will take the antibiotic by themselves. And now the drugs are available online. You have got so many online pharmacy or over the counter. So this is also one of the again driving force for which it can lead to self-medication also. So let's look at certain common examples of irrational prescribing. Use of drugs when no drug therapy is indicated. Now that's a very common thing, like using antibiotics for viral respiratory infections. Second, wrong drug for a specific condition requiring drug therapy. For example, here, like an antibiotic in childhood viral diarrhea, where it requires only oral rehydration solution. You don't require therapies. Next would be drug with a doubtful or unproven efficacy, like anti-motility agents used in acute infective diarrhea. In fact, that should not be used. Then correct drugs, but incorrect administration, dosage or duration. So like use of IV metronidazole when a patient might as well take oral preparation also. And unnecessary expensive drugs like using a third generation compound when even a first generation compound can do the same work. So what is going to happen? You are not only loading him with a more powerful antibiotic, but at the same time it is definitely going to be a more expensive therapy also. So if you look at to overcome this, the steps were started taken by arbitrary statutory bodies also. So in 1977, the first step towards the rational use of medicines was introduced, and WHO established the first model list of essential medicines to assist the individual countries. And in 1989, INRUD, that is International Network for the Rational Use of Drugs, was formed, and basic purpose is to promote more rational use of medicines. And as I said, since 2008 at European level, now it is 18 November to 24th November is known as the Awareness Week for the rational use of antibiotics and antimicrobial resistance. So how do we overcome all these issues and all? So obviously the rational use of medicines, and there are various components to it. So prescribing the right drug in sufficient dose for an adequate period of time at the lowest cost to patient and their community. So all the components are very important. If you remember my case which I showed, the first patient received, first of all, giving for viral infection, azithromycin not indicated. Second, if given 250 milligram per day for a 70 kg person, again not the right dose. If you are starting giving for 3 days, again not the right duration. So these all multiple factors are adding on to it. Of course, we need to take care of various other factors like healthcare workers, patients, patient loads and healthcare facilities. And that is how what is important or training for rational drugs, years of practice and educational background, which plays a very, very important role in that. So let's understand there are 12 core interventions to promote more rational use of medicines. And what are those? A mandated multidisciplinary national body to coordinate medicine use policies, and that is now most of the countries have got their in-house these policies are there. Next, clinical guidelines, which is very important, and the practitioners should get themselves updated with these guidelines. Essential medicines list based on the treatment of choice. Again, it would be a country specific, and then you will have those choices of selection of drugs. Drugs and therapeutic committees in districts and hospitals. And now, if you see, all tertiary care hospitals have got their own underlying committees which formulate and give the guidance about the usage of antibiotics. Problem-based pharmacotherapy training in undergraduate curriculum. Again, it's a very important problem. You have a pharmacology is one of the subject in second year MBBS. But specifically focusing on this area is also very important in that. Continuing in-service medical education as a licensure requirement, then it will become mandatory for most of the practitioners. Supervision, audit and feedback. It is started happening in higher centers, but it should come to even a primary healthcare center also. Independent information on medicines, again very important. Public education about medicines. Avoidance of perverse financial incentives, again a very important message. Appropriate and enforced regulation, and sufficient government expenditure to ensure availability of medicines and staff. It is been told by lot of people about the health care budget from the government should definitely need to be improvised, and if that comes, again that's going to add value to it. So here I would like to say what are the things which has been recommended by various societies. So one important message about the International Society of Chemotherapy put together 10 recommendations for physicians. And what are those? Use antibiotics only when needed. So that is very important point. Select the adequate antibiotic, precise targeting better than a shotgun therapy. So you need to identify where is the infection and then you need to prescribe that. Consider the pharmacokinetics and pharmacodynamics when selecting an antibiotic. Now what is pharmacokinetics? What the body is doing to that drug. And what is pharmacodynamics? What the drug is doing to the body. So that is one important point which we must understand. Encourage patients' compliance. We must understand certain drugs maybe have to be taken 3 times a day, but you need to see that the patient is going to take that 3 times. If you know that patient is not going to take, please don't prescribe such medicines. Go for a drug which can be given once a day. Use antibiotic combination only in specific situations. Avoid low quality and substandard drugs. Discourage self-prescription. That's the most important key factor. Follow only evidence-based guidelines and rationally rely upon the clinical microbiology lab. So as and when needed, we need to use or take the help of microbiology assist. And prescribe antibiotic empirically as and when needed, but intelligently. So that will be a very important point also. There are certain other recommendations like obviously as I already mentioned, please do not prescribe antibiotic when it is not needed. For example, bronchitis when pneumonia is not a concern. Don't use antibiotic for watery diarrhea when or of course only when if is a dysentery or typhoid fever which is there, that's a different thing. Delay the use of antibiotics against otitis media for at least 48 hours when you know that it is not superadded bacterial infection. Consider nitrofurantoins instead of fluoroquinolones against uncomplicated cystitis. Reserve respiratory fluoroquinolones or for unresponsive or high risk community acquired pneumonia, and avoid fixed dose combinations. Now a lot of pharma companies have come out with those fixed dose combinations of antibiotics, but try and use your rationale in selection of those drugs. I already mentioned about the registration and the licensing and how the authorities can help in curtailing this menace of antimicrobial resistance. So that would be a very important point. I will quickly go through certain recommendations because due to paucity of time cannot cover all the conditions. So like for example, if somebody has got a acute rhinosinusitis, so amoxicillin or co-amoxiclav or amoxicillin clavulinate is the recommended first line therapy. Remember here, macrolides such as azithromycin are not recommended due to high levels of strep pneumonia antibiotic resistance. So which you must keep it in mind. So again, selection of antibiotic will be a very, very important factor over here. Another example, acute uncomplicated bronchitis. Now, routine treatment of uncomplicated acute bronchitis with antibiotic is not recommended. regardless of cough duration. Now remember one thing, no, somebody will say now he's coughing for now 7 days. That is not a criteria to start antibiotic. So you need to look into it, what could be the etiology, what could be the factors, and then what are the options for giving therapy. So such patients you can give cough suppressants, first generation antihistamines or decongestants, and that is what for symptomatic relief. Of course, your patient is expecting a symptomatic relief from you, but that doesn't mean you give antibiotics and it is going to do something magic over there. If you think as pharyngitis, again amoxicillin or oral penicillin, penicillin V remains first line therapy due to their reliable antibiotic activity against group A streptococcus. If somebody who has got a penicillin allergy, the next options would be cephalexin, cefadroxil, clindamycin or macrolides, which can be recommended. And gas antibiotic resistance to azithromycin and clindamycin are increasingly common, which we should keep it in mind. I already mentioned about acute uncomplicated cystitis. Obviously, the drug of choice will be nitrofurantoin or trimethoprim sulfamethoxazole combination, or even now fosfomycin, which is also been used, but fluoroquinolones should be a reserved one, so that you should keep it in mind. Again, conditions like common cold and non-specific URTI, the decongestant combined with first generation antihistamines, if required, NSAIDs may be used. There is no need of antibiotics. Here I would like to mention about the problem about the macrolides, which is seen, or rather the issue about the resistance to macrolide in this COVID-19, because the macrolide used has increased like anything in this current COVID pandemic. Azithromycin, which has been recommended as, of course, one of the repurposed therapy against SARS-CoV-2, though there is no substantial evidence. Now, what has happened? Look at the data. In Spain, example, azithromycin use in March 2020 was 400%. Its use in February 2020 when it started. So, such a huge jump. And so, clinicians who manage COVID-19 patients must consider this possibility of development of resistance of macrolides in the community, and in a time to come that should be kept in mind. So friends, remember one thing, there is no such universal antibiotic good for all infections, and the newest antibiotic may not be necessarily the better antibiotic. That is a very, very important message over here. In fact, now as I was mentioning, every country has their own guidelines and recommendation. In fact, there is a National Center for Disease Control, even the Director General of Health Services, Ministry of Health and Family Welfare, Government of India itself has come out with this national treatment guidelines for antimicrobial use in infectious diseases, which is available on website, so which we can definitely refer to, and that will give us a good guidance in deciding the antibiotic therapy. So friends, non-compliance and non-adherence to antimicrobial therapy is a major factor contributing to antimicrobial resistance. So I would end with these 10 steps for the correct usage of antibiotics. The questions we need to ask about: first, is an antibiotic indicated on clinical grounds? Second, have appropriate investigations been performed as and when needed? Third, what organisms are most likely to cause this infection? Is it gram-positive? Is it gram-negative? Is it anaerobic? Or is it non-bacterial infection? Which agent is best? So that would be again depending on what you are suspecting. Next would be, is an antibiotic combination appropriate? Does this condition really needs to be given antibiotic combination, or a single antibiotic is good enough? Are any host factor relevant? That means, is the patient having diabetes? Is he immunocompromised? What is the best route of administration? There are so many drugs where whether you give orally or parenterally, there is no difference. For example, quinolones, it is same. So you need to see if your GI system is active, you might as well give orally. There is no need to give parenteral. what is the appropriate dose? Very important point. Can therapy be modified when lab results are obtained? So many times when you sent a culture, you got a results, you got an antibiotic sensitivity pattern, and accordingly you can choose the finally modify the drug. And last question, what is the optimal duration of therapy? That you need to take a call. Overutilization or underutilization, both are detrimental for the patients. So I will end with this quote by Thomas Alva Edison. States that I will not say I failed 1,000 times. I will say that I discovered 1,000 ways that can cause failure. Thank you so much for your patient hearing, and definitely we would be happy to have the questions which we'll take at the end. And now we'll invite my dear friend Dr. Agam Vora, who is a committee member of IMA Mumbai West. He is also right now the elected Honorary General Secretary of Association of Physicians of India. He has been the Honorary General Secretary of Academy of Advanced Medical Education. He has been a past president of Geriatric Society of India and a very near and dear friend of mine. So may I invite Professor Dr. Agam Vora. He will be talking about the use of antibiotics in hospital and ICU setting. Over to you, Agam.
Wow. Thank you, Dr. Ketan Mehta. It's always pleasure, as Ketan said, to be in your own home ground. And I'm so sorry that I'm not there with you physically, just couldn't make it, but it's real pleasure. And the topic also is very dear to my heart, and we are going to be talking about antibiotic resistance. And I will be focusing on the issues of antimicrobial resistance in hospital settings and in ICU. To begin with, I must express my sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty, organizer of today's program, and that is IMA Mumbai West. I'm so happy that Dr. Jialal is here. I really fail to understand how Dr. Jialal manages this time. And I could see that he was traveling, and in spite of that, he continuously was connected and he was present all throughout Ketan's talk, and that talks about his commitment to the subject. My mentor, Dr. Jayesh Lele, my everyday morning coffee with Dr. Lele, and he's been a continuous source of inspiration, currently holding the post of Secretary General with IMA headquarters. My dear friends, Ketan, Dr. Mangesh Tivaskar, who's going to be talking after me, all of you who chose to be here, it's only your presence that says how important is the topic and your commitment towards the antimicrobial resistance. My family, of course, the educational partners for today's program, that is GSK and the backend team, the technical support team, everybody. A big thanks to all of you. This is the Antimicrobial Resistance Awareness Week. And this week, it is aimed to increase awareness of global antimicrobial resistance and to encourage the best practices in everybody, in general healthcare providers, the policymakers, you and me, to prevent the further emergence of drug-resistant infection. And the theme is spread awareness and stop resistance. The slogan is antimicrobials, handle with care. So this AMR, or drug resistance, which includes the antibiotic resistance, is a growing public health issue and needs urgent attention. Estimated 7.5 lakhs people would die annually. And if I make very rough calculation, it would mean approximately 2,000 patients would die daily, which in again rough calculation, one patient would die every minute because of this problem of antimicrobial resistance. And it causes a definite strain on the health system. There are a lot of studies, and I think it is quite understandable that there are financial consequences, including extremely high healthcare cost. As this patient would require for sure admission, would require longer stays, would require intensive care, would require isolation, would require extensive and intensive therapy. You would be forced to use less conventional drugs. You will be forced to use different combinations, and which has its own complication. If this issue is not addressed urgently, tens of millions of people will be forced into extreme poverty, hunger, and malnutrition. And hence, it has got huge significance. The outline of my presentation for next 25-30 minutes is going to be introduction to this resistance, the causes, the use, the mechanisms of resistance, susceptibility patterns, and some strategies to tackle it. When I look at the top causes for the whole existence, your and my existence on this planet Earth, that means what are the most important factors which are global drivers for human existence? And when you have all those issues taken into consideration, your urbanization, your money power, your nuclear issues, the bioterrorism, I mean the international terrorism, etc., green gas. When you look at that, antibiotic resistance is second most important. That is, this is the second top most important factor responsible for our existence on this planet Earth. And look at these slogans. CDC came out with some smart slogans for in-hospital antibiotic prescription. It says 1 in every 3 patients will receive 2 or more antibiotics during their hospital stay, and not uncommon for you to witness. You as a family physician also have seen patients of myocardial infarction gets admitted and receives 1 antibiotic. Patient of viral diarrhea, dysentery gets admitted and receives a course or 2 of antibiotic, which is not needed. Of the patients receiving antibiotics, 3 out of 4 will receive unnecessary redundant therapy, resulting in excessive use of antibiotics. So what is resistance? Resistance is the ability not to be affected by something specially adversely. Antibiotic resistance is the ability of a bug to develop resistance to effect of antimicrobial medicine. And the antibiotic resistance is a small subset which applies to bacteria. So whenever you're talking about bacteria, it would be antibiotic resistance. And when we are using it for various other microbes, it is called as antimicrobial resistance. These resistant bugs are difficult to treat, require higher dosages, would require alternative therapies, and are more toxic. The approaches could be expensive. Antimicrobial resistance occurs when bacteria change their response to use of this antibiotic, which are used for treating these infections, rendering this antibiotic ineffective. You have this antibiotic which acts on this bacteria and kills it. But in presence of the antibiotic resistance, bacteria change with antibiotic use, infection would persist, and there is increased risk of spread of infection with this resistant bug, and eventually the antibiotic becomes ineffective. There are certain different terminologies. I thought I would spend some time on the differentiation. The antibiotic resistance is different with the virulence, though they are interlinked. Antibiotic resistance means it came only after the evolution of antibiotics. It overcomes therapeutics. There is gene transfer mechanism also is involved. And though it is linked to virulence, it's a separate thing. Whereas virulence is inherent bacterial ability for causing disease. It fights the immune system of host, and it is linked to resistance. So there are both different terminologies, though they are interlinked. Again, these are 2 different things. One is resistance and second is persistence. So if a bacterium is resistant, say you are using penicillin and the bacteria is resistant to penicillin, all new baby cells of progeny bacterium which are developed would also be resistant to penicillin, whereas persistent is even if they are sensitive, some cells may remain dormant. For example, your Mycobacterium tuberculosis, it can remain dormant for years together. Only the sensitivity will be understood when they get active or when they divide. And the resistance mechanism could be natural or could be acquired. Natural would be intrinsic, always expressed in chromosomal gene. It is induced by expression on exposure to certain level of antibiotics. Whereas acquired would be, you have an acquisition of resistant gene, that is plasmid mediated, what we say, and then there are mutations which give you acquired resistance. And the causes inadequate regulation and antibiotic usage, the commonest cause. Very easy availability of this drug, over-the-counter availability of this drug. Usage imprecision, your wrong choice, your wrong dose, your wrong duration, lack of awareness regarding best antibiotic practices, unwarranted and inconsistent use of antibiotics, and not only that, the major chunk comes from antibiotic usage in non-human form, that is your poultry and livestock growth promoters rather than infection control. So these antibiotics are used to promote growth, and that leads to huge problem of antibiotic resistance. And 50% of this antibiotic, me and Mangesh have done some study. We spoke to a couple of family physicians on phone, a couple of colleagues on phone to find out about the common choice of antibiotic they have and the indication. And we realized more than 50% antibiotics are used, wrong antibiotic for wrong indication. Your choice of antibiotic was wrong. So you have urinary tract infection, which is gram negative, and you use gram positive antibiotic, like use a macrolide, which is a wrong choice. The wrong dose which is used, Ketan said, 250 milligram for 70 kg, wrong. Duration of treatment, again, undertreated, underdosed, 3 days, 5 days, 7 days, and the route of administration. So there could be so many fallacies. More than 50% of medicine prescribed, dispensed, or sold are inappropriate. And half of all patients fail to take these medicines correctly. They forget to take the right dose. That means you told them to take it 3 times a day, they may take it twice. You have told them to take once, they forget to take it. You have told them about 5 days, 7 days, 10 days, and they would take it 3 days, 4 days, depending on the commercial pack available. The overuse, underuse, misuse harms people and would lead to resource wastage. More than 50% of the countries do not implement basic policies to promote rational use of antibiotics. And in developing countries, less than 40% in public and 30% in private sectors, treatment is given according to guidelines. That means we don't follow guidelines. Overprescription is a problem, not only with you, not only with me, it is a global problem, worldwide problem. Inappropriate indication, inappropriate agent choice, and inappropriate duration is responsible in almost 50% of the times. And the highest drug which is consumed is in countries like Brazil, Russia, India, China, and South America. That is, these BRICS countries are using it maximum. And what comes as a big surprise when I looked at this chart, it tells me that majority of the antibiotics are used in younger patients. Imagine 0 to 4 years, out of 1,000 prescriptions, 36 prescriptions were used for younger. And so is the elderly population. And when it comes to the choice of antibiotics, some beta-lactam, that is your penicillins and cephalosporins, are the commonest prescribed antibiotics. And the indication for which it is used is acute upper respiratory, lower respiratory, cough, nasopharyngitis. Majority of the indications are respiratory indications. And of course, there are other indications like urinary tract infection, sepsis. When you look at the available armamentarium that you have, the available antibiotic you have, you can classify it depending on the classes like your penicillins, macrolides, quinolines, cephalosporins, etc., etc. You may also look at the mechanism by which they work. So you have a cell wall synthesis inhibitors. All commonly used antibiotics like penicillins, cephalosporins, beta-lactam, that is your carbapenems, they act on cell wall synthesis. Cell membrane disruptions like polymyxin. There could be folate synthesis inhibitors like sulfonamides and trimethoprim. There could be RNA translation inhibitors like aminoglycosides, tetracycline, macrolides. Transcription inhibitors like rifampicin. DNA synthesis inhibitors like quinolones. So these are the various group of drugs that we commonly prescribe in our practice. And let's look at what are the ways in which bugs develop resistance. The commonest is the presence of enzyme. So there are certain pelicinase enzymes which are released and they make antibiotic inactive. So you have a bug which releases this enzyme, making it inactive, and antibiotics cannot work. You have the changes in the shape of receptor. There are PBPs, protein binding proteins. The change in shape of this inhibitor will not allow this drug to bind on it, and hence there will be resistance. This is due to mutation which occur. There is efflux mechanism, in the sense the drug enters into the cell wall, but there are drug pump available which throws this drug out of the cell, making it lesser concentration available in the cytoplasma, making it again inactive. And use of alternative pathways. Bugs would develop alternative pathways of metabolism. And if this is the pathway antibiotic works, they would develop another pathway and would render them ineffective to the medicine that you use. Then comes the concept of ESBL. You imagine this is the antibiotic and this is the bacteria. There is a cell wall there. The antibiotic, say penicillin, would act on the cell wall, would bring about disruption of the cell wall, and the bug would be lysed. Imagine if this bacteria has a capacity of releasing certain enzymes. These enzymes would make this antibiotic ineffective. inactive before it touches the cell wall, and hence there is no antibiotic available for its action. This is called ESBL producing bugs, that is beta lactamase producing bug. So whenever you have hospitalization for more than 48 hours, patient of immunosuppression, patient has received antibiotic in recent past, patient is elderly, diabetic, or kidney failure, patient of burns, who's got catheters inside. These are the patients who have ESBL producer bugs. And in that situation, you may have to use a beta lactamase inhibitor. So you have to use beta lactamase or extended spectrum beta lactamase inhibitors to make this antibiotic susceptible. Like in penicillin, you may have to use sulbactam or the drugs like that. So these are the enzymes. This antibiotic would now come with the ESBL inhibitor. And when this antibiotic is exposed to such enzyme, this enzyme will not act on antibiotic and would allow antibiotic to act on the cell wall. So these are various ways in which antibiotic resistance is developed, and some of the ways in which this antibiotic resistance can be managed. And whenever there is an infection population, there is a mixed pattern. So there are not all bugs which are resistant. There may be a sensitive bug and there may be a resistant bug, and the drugs that you use will have influence on this resistance transmission. The burden of resistance is maintained under a certain acceptable level with the use of specific antibiotic and with the periodic change in the antibiotic policy. So imagine a situation you have extensive irrational use of antibiotic will lead to expulsion of all sensitive bugs, would make you only resistant strains available. You use incomplete dose, say you use half the dose, 1/4 the dose than what is required. This misuse will lead to non-complete eradication of bacterial colonies and would make them resistant eventually. Self-medication, all easy to available over-the-counter medicine would lead to increased antibiotic consumption, and this complex interplay of population ecologically of infectious disease with your socioeconomic growth, with antibiotic consumption in available with over-the-counter medicine would lead to emergence of resistant strain and will have impact on social, economical, and behavioral norms. CDC has given a list of serious threats. You have urgent threats of this molecule like carbapenem resistance Enterobacteria, Clostridium difficile, drug resistance Neisseria, and you have serious threat with multi-resistant Acinetobacter. You have fluoroconazole resistant Candida, vancomycin resistance Enterococci, drug resistant Salmonella, drug resistance Streptococci, and not to forget drug resistant tuberculosis. And then there are concerning threats with vancomycin resistance group, erythromycin resistant Streptococci, and Clindar resistant Streptococci. And then is the concept of the superbug, where there is increased virulence and improved transmissibility, which can transmit faster and has got super resistance. There are several mutations which provide a multiple level of protection to this bug. And whichever antibiotic you use, lesser availability of therapeutic options, prolonged stay, higher mortality and morbidity. Look at this antibiotic susceptibility results of a respiratory infection. More than 230 samples analyzed, 86 were culture positive, and the important bugs were gram-negative bugs. I was told respiratory tract infection is always gram-positive, and gram-positive. And now we are changing, now we are seeing this change in trend where we have difficult gram-negative bugs. We also have gram-positive bugs like Streptococci, which are multi-drug resistant. Again, when you look at the sensitivity, for this bug, you realize that there is significant resistance to carbapenem as well. Carbapenem is like your meropenem, and you have now doripenem and so many penems, and you have resistance to carbapenem as well. Look at gram-positive bug, vancomycin and linezolid. You have for staph and streptococci almost 176% susceptibility and 72% susceptibility respectively, which would mean that there is a detailed bacteriological diagnosis and susceptibility testing is required to overcome this global antibiotic resistance issue. And this was for enteric fever. First line therapy, I'm sure you all know that ceftriaxone would be a first line therapy, but in this, so many patients where they required second and even third drug. They required second drug is ofloxacin and third drug is azithromycin was also required. And that is, it speaks that probably one drug may not be enough and you have to think out of the box, may have to combine 2 or 3 antibiotics to treat simple infection, which we were treating with oral antibiotics probably a decade earlier. What are the reasons for this overuse? There are patient concern. They want clear explanation, they want quick recovery, and they want to go back to work as fast. Patient expects antibiotic in most of the situation, diagnostic uncertainty and time pressure. If you ask for investigation, there is a high turnaround time, and which would make you prescribe antibiotic earlier. If I give you my example of being a chest physician, what are the diagnostic challenge for pneumonia? For pneumonia, patient does not present with typical pneumonia symptoms. Clinical scores are available, but then not everybody is using it. X-ray is useful, but normal X-ray will not rule out pneumonia. You need various other tests to confirm diagnosis. The challenge is there are no good diagnostic tests available. Establishing etiological diagnosis in a classical community-acquired pneumonia will be only in 50% of the times. In the sense, you ask for all those fancy tests, you ask for cultures, blood cultures, sputum tests, etc. Still, only in 50% of the cases you will have answers. Otherwise, you may not, because getting good quality sputum may be difficult. Whatever material you collect, you send it for test, and would give you wrong answers. And then comes the issues of false positive and false negative with your prior exposure to antibiotics. Challenge is that you and me face in hospital when patients are admitted. Your high turnaround time. You ask for cultures, would take 3 days. You ask sputum collection, would take 3 days. Limited access to quality laboratories. Whenever I speak with my colleagues, most of them complain about inadequate, good quality lab. And fault is with us also, where we don't really convey what we want. We don't communicate well with our microbiologist. High cost of diagnosis, low quality sputum sample, and low sensitivity of cultures. There are so many advancements which happened in last 50, 60, 70 years that we came out with various newer technologies for diagnosis. We came out with DNA discovered, then a polymerase technique isolated, then PCR developed. We developed DNA microarray. We found out DNA real-time PCR. We find out Binax now. There is a mass tech PCR developed. So many molecular tests are developed, but the result immediately, as we got wiser, bugs also kept on getting wiser, and you have all possible resistance. You have MRSS came, multi-drug resistant tuberculosis came, then came actually the totally drug resistant tuberculosis. You have multi-drug resistant Pseudomonas and Acinetobacter, and you have pandemics which came in. The future is on technologies. We historically spend our time on microscopy and cultivation, that is culture. Then came the urine antigen test, then came PCR test. And when host targeted, we developed certain techniques like certain tests like CRP and procalcitonin. Of course, we had all cellular and molecular tests available. Currently, we are focusing on microbial metagenomics and metatranscriptomics. And future holds that you will have a direct specimen of DNA and RNA sequencing. You will have molecular quantification. You have exhaled breath analysis, and integrated study of microbe and host response will be the future. If I again talk about respiratory cases, you have so many tests available. You have cultures available, you have blood culture, you have chest X-ray, rapid antigen test, you have PCRs. And there are sheer advantages and disadvantages of each. Rapid antigen test, you know that answer is available in no time, but you can get very high false negative. It could be unreliable in non-serogroup infections. PCR is highly sensitive and specific, but it takes some time. Accessibility and technical demands could be a limiting factor. Blood cultures gives you definitive answer, but is positive only in 10% of pneumonia cases. And of course, takes 2 or 3 days. There are newer tests available called BioFire test, where there is an endpoint melting data curve system available, where software automatically analyzes for whatever antigens you're testing for. Say, for example, there is a new respiratory panel available called PCR22 and gives you answer against this 22 viruses in no time. You just take a tracheal or the nasopharyngeal swab and send it for respiratory BioFire panel, and you can get the etiological clue, whether it is coronavirus. There are 4 variants, influenza A 3 variants, influenza 4 variants, syncytial virus, adenovirus, also Bordetella, chlamydia, and mycoplasma can be identified in no time. So you have cultures, you have molecular, that is single plex test available, and your molecular, that is multiplex. The BioFire is multiplex, where you can check for multiple antigen. You have single antigen test, like your urine test. I'm going to talk to you about it. You have urine Legionella test available. You have urinary streptococcal test available, which has got high sensitivity and specificity. Cost not really very costly, it costs somewhere 900 to 1000 rupees, but it will detect only for that pathogen. Say you're suspecting Legionella, you do Legionella test, it is negative. It just tells you that it is not Legionella, but what it is, it may not tell you. Where if you have multiplex, it is very specific, sensitive. Cost is a concern, but it will tell you about whatever common bugs which are available in that. So this is, I was trying to tell you, urine antigen test. Very easy to take it. It's like your urine pregnancy test. Patient could use your washroom, can collect a sample of urine, put it on the cartridge available, and it will give you answer in 30 minutes, and it will tell you about whether it is streptococci, whether it is Legionella. Only problem is polymicrobial infection is not identified. The advantage is if you've already started antibiotics, still it can be positive. Once you have your culture reports available, you can get specific on antibiotics. You have streptococci, you have Legionella, you have chlamydia, you have whichever bug, you have preferred antibiotics available. So you could choose from the available guidelines regarding the use of antibiotic. This is again for Pseudomonas, Burkholderia, etc., etc. And if this is not possible, there is given a second option as well. You could choose depending on if patient has any comorbidities or if sensitivity pattern talks otherwise. And in ICU, there is always a dilemma that prescribing antibiotics to treat a critically ill patient with serious infection while minimizing the emergence and spread of resistance. And trust me, even if there is 1 hour delay in prescribing antibiotics in ICU, and in fact, the recommendation is to initiate first dose of antibiotic in emergency room itself, the mortality could be as high as 30%. In the sense, if you don't start antibiotic in time, there are chances that you would lose patient, a significant number of patients will be lost. And what are the risk factors for delayed antibiotic therapy of appropriate antibiotics? So whichever antibiotic you choose, chances of it being appropriate if patient is infected with bugs in recent past and you don't have history. Say patient is admitted in 90 days and was exposed to antibiotics and you have no clue. Prior antibiotic exposure would promote colonization and subsequent infection with resistant bug, complicating your initial choice of antibiotics. And hence, you will not only require novel antibiotics, but you will also require an alternative non-antibiotic strategies for prevention and treatment of infection. During this COVID-19, all of us, you, me, and everybody has misused antibiotics. We have used all possible antibiotics for COVID-19 in spite of we knew that COVID is a viral disease. And macrolides, and not only macrolide, but all these antibiotics which were given when patients were hospitalized were completely misused. So we have piperacillin, we have amoxicillin, we have tigecycline, meropenem, aminoglycoside, beta-lactam, beta-lactamase inhibitors are the various group of drugs that we routinely use in our hospitals. And if you have to design a rational policy for antibiotic therapy, one need to have a written protocol. If you make a simple written protocol, by just doing that, you can really cut down the misuse of antibiotic. And that should be based on actual medical knowledge with the available guideline and the culture sensitivity flora that you have in your ICUs in your hospital. And whenever you do this, a reassessment of current therapy must be done regularly. On day 3, day 7, day 10, you need to reassess patient, look at your antibiotic choice, look at the available data, look at the culture sensitivity pattern report that you have, look at the antibiotic that patient has received in past, and accordingly change your antibiotics or de-escalate your antibiotic. You may have started with wide spectrum antibiotic, but once you have answer, you can narrow the spectrum. Preference for oral over parenteral route of administration. Even if patient is in hospital, one must think of converting it to oral. And intensive care, it is possible to implement a program of cost control for drug use while respecting medical concerns. The impact of quality healthcare can be monitored by assessment of parameters reflecting the unit's activity. Antibiotic prescription would be empirical in most of the times in ICU, but one must change over to appropriate antibiotic utilization the minute you get wiser, the minute you have sensitivity reports available. And not only treating the patient, unless you analyze the data you have, unless you focus your research on what are the infections you are seeing in your area, what are the antibiotic practices by your colleagues in OPD setting, what are the sensitivity pattern of the bugs that you're seeing, and what are the kind of infections you're seeing, whether it is pneumonia, bacteremia, urinary tract infection, sepsis, whatever. And if you have regular meetings with your colleague to understand, then only you can get wiser and minimize the misuse of antibiotics. When patients don't respond, if there is failure to improve, and if there is worsening happening in 24 to 48 hours, you know that you are probably dealing with resistant bugs, or you have not really used the antibiotic which would be required for the infection that is suspected. Patient may have developed nosocomial infection. It may be a non-infectious cause of worsening. If patient deteriorates in some time, you know that this kind of treatment would require a change. Definitely, we must put enough attention on prevention. How can I not talk about prevention before I end my talk? We at IMA have taken extraordinary steps. We have spent almost 1 year in developing a live course immunization document, and I feel very sorry when I don't see my colleagues, you and me, prescribing vaccination to its needed extent in adult population. It is not only for diseased people, it is for every adult. Like you do child vaccination for every child, you and me and every family member of yours and every patient of yours requires vaccination. Do refer to the vaccination document and please vaccinate all your patients on priority. The other measures that you will undertake is you will look at antibiotic stewardship for judicious use of antibiotics, and Dr. Tivaskar is going to be talking about it. Strict vigilance and control of antibiotic sale, regulation of hospital and pharmaceutical discharge, rules and regulation for use of antimicrobial agents in food and in animals, environment-friendly maneuvers in fertilizers and agriculture, and of course, education, the initiative like this that IMA has taken. The key prevention strategies, you have a bug there, which will lead to infection. You will use antimicrobial. There will be resistance of antimicrobial, and that would lead to antimicrobial resistant bug. What you can do is you can prevent the infection by good hygienic practices. You can do effective and early diagnosis and would choose treatment wisely. Give the antibiotic, right dose, right duration, and that would lead to antibiotic sensitive bug, and find out the ways of preventing this transmission. That means do not forget to vaccinate all your patients. Antibiotic resistance is the ability of bacteria and fungi to resist or defeat effect of drug that you've used. Antibiotic resistance could be natural or intrinsic, or it can be acquired. The major cause is inappropriate antibiotic use, and this irrational use support the propagation of resistant strain of bacteria. Mechanisms of resistance include modified entry and exit of antibiotics, modification of antibiotic proteins and target molecules, and strategies to combat antibiotic resistance are rational use, regulation of OTC drugs, hygiene practices, and awareness regarding resistance. Trust me, antibiotic resistance is inevitable with its use. The minute you have a new antibiotic, the minute you start using antibiotics, there will be a resistance. There is no new class of antibiotic which is going to be introduced over the next 2 decades. In the sense, probably in your and my lifetime, we are not going to see any new antibiotic. Appropriate use is the only option. I want you all to take a pledge with me. Ketan, I request you to tell everybody to take a pledge with me. And I want all of you, all healthcare providers, especially of IMA Mumbai West branch, to take a pledge that we will not misuse antibiotics. Please take a pledge with me and say that we will not give routine prescription of antibiotics. We would for sure avoid the use of quinolones in our OPD infection and would reserve it for tuberculosis. If you reduce your antibiotic prescription, even if one prescription of antibiotic you think twice today, I think I would consider my talk has conveyed the message that I wanted. I would conclude by saying that every antibiotic expected by a patient, every unnecessary prescription written by you and me, and every uncompleted course of antibiotic, it is potentially signing a death warrant for a future patient. It is a death warrant for your and my children when they require antibiotic, because we'll be left with no antibiotics. Thank you very much for your patient hearing.
Thank you, Agam. It was a fantastic presentation, and I'm sure the final warrant or death warrant which you have just given them, I'm sure all our practitioners are going to take a lesson out of it. So friends, with this we will move on to our last presentation. I would of course request Dr. Agamora, he will be present for the Q&A at the end. And now the last but not the least, the very important part of today's program, and that is talking about antibiotic stewardship program. Friends, to talk on this subject, we have a masterly orator, none other than my very dear friend, Dr. Mangesh Tivaskar. Now, to introduce Dr. Tivaskar is like taking a full session. And definitely, I cannot afford to do that, but I'm sure he doesn't require any introduction. At present, he is the Honorary General Secretary of Association of Physicians of India, in Indian College of Physicians, and also in PRF. He has been actively involved in lot of organizations, be it RSSDI, be it API, be it Academy of Advanced Medical Education, so on and so forth. To tell you, he has a very brilliant academic career. How many gold medalists he has achieved. Probably when he got married, probably they never thought that this guy is so rich, loaded with so many gold medals. Obviously, his wife, I know his wife very well, Shilpa, the family was so thrilled that this guy is loaded with gold. With these words, of course, we can go on and go on, but I invite my dear friend, Dr. Mangesh Tivaskar, to deliver his talk. Over to you, Mangesh.
Oh, wow. Thank you, Ketan. And I'm always very thrilled and excited whenever you introduce me. And of course, your session and Agam's session was mind-boggling. Honestly speaking, both were jaw-dropping session, and I must compliment both of you. Along with that, I would also appreciate the efforts being put by entire IMA team, especially Dr. Jayesh Lele, Dr. Jayalal, and entire support staff, along with today's sponsors, for choosing this topic of discussion today. Why it is important is basically because, as Ketan has already told, and even Agam has mentioned about it, that we are celebrating the antibiotic stewardship week. But my basic question is this, that is it that these kind of weeks are we going to really need? Can't we celebrate these days and throughout our practice? Can we not have the components of the antibiotic stewardship practiced every day and hour? Can they not be a part of our routine daily behavioral patterns? Think about it, and I believe that this is a worth I would say thought for a pondering. So thank you once again, Ketan, for beautiful introduction and a lovely concept. And of course, my discussions that I'm going to have are completely dependent on the review of the data which is available. And of course, I'm going to talk to you about what best you can implement. Ketan and Agam both have given you what are the areas of concern and what are those few things. Ketan partially covered some areas of antibiotic stewardship, especially when it comes to OPD practice, and Agam talked beautifully about smart use of antibiotics. More importantly, we need to understand, as Agam's last slide was talking about, I would like to give an example. Say, suppose this was 1945, a 20 years old girl gets admitted in the hospital with a community acquired pneumonia, gets treated with penicillin. Within 7 days, the girl recovers, goes back home, family and the entire community is very happy. Now, same typical kind of a community acquired pneumonia scenario, gets admitted in the local nursing home with community acquired pneumonia, a 22-year-old girl, and now keeps on getting complicated because whatever the antibiotics that she is receiving, they are not effective. And ultimately, we lose the girl. Now, this is what we are looking into. So if you are not really prepared to look deep down the barrel, we need to really take care of possible, I would say a time that we are going to foresee is the situation of bad bugs and no drugs. And if at all you don't want to really go into that, and why it is important for all of us to understand is that because now even media is reporting, and look at the Times of India article which got published in a couple of years ago. But the most important aspect is that look at the number of deaths which are expected at the end of this probably 2050. Nearly 10 million lives will be lost every year. And you know how much antibiotics entire India really consumes? Agam has beautifully shown that. We consume mostly 19 tons of antibiotics in entire year. And unfortunately, majority goes for the wrong usages in the veterinary areas. So antimicrobial stewardship program, we definitely need a guideline to look at, because we definitely don't want to enter the scenario of bad bugs and no drugs. So it's a balancing act that we need to all achieve. And this is a joint effort. It's not the joint effort just by the healthcare providers, but also it's a joint effort from all the possible stakeholders. We need to join hands together to achieve the proper initial antibiotic use. Usually when it comes to the empirical antibiotics therapy, till the time you get the data of culture and various other tests available, and also try and stop unnecessary use of antibiotics, especially the broad spectrum antibiotics. And Ketan has told you about penicillin, and there was a World War II picture where, beautifully the tagline was, "Thank God that they'll come home." But how I would say mesmerizing was the thought process of Dr. Alexander Fleming, that in his Nobel lecture, he mentioned that it is not difficult to make microbes resistant to the penicillin in the laboratory by exposing them to the concentrations which are not sufficient to kill them. And the same thing has occasionally happened in the human body. And the time may come, and unfortunately it is true in India especially, that when penicillin can be bought by anyone in the shop. Now look at penicillin as probably a representative of antibiotic and replace penicillin by an antibiotic. Then there is a danger that an ignorant man can easily underdose himself by exposing his microbes to the non-lethal quantities of the drug and make them resistant. Now this is 1945 Nobel laureate lecture, the Nobel diploma lecture delivered by Alexander Fleming. This side actually I just was accidentally hit, but this has really taught me so many things, that if you really look and put the entire life which is born on the earth on a clock, and put the all developments of different forms of life, you will see that at around 4 o'clock in the morning the life has truly started, after the meteorite bombardment which happened between 0 to 3 hours. And then at the 4 hours, bacteria and microbes they came. And look at then the clock kept tickling, and look at when the mammals are born, 11:58. Now why I'm showing this slide is because we need to understand that we could never ever be able to overrun the bacteria. We never outrun the bacteria. So we must stop creating selective pressure on them. And antibiotic stewardship is mandatory. All of us need to remember that. So what do we know about? What is the definition of antibiotic stewardship or antimicrobial stewardship? It's an organizational or a healthcare system wide approach for fostering and monitoring the judicious use of antibiotics. And it's not, I'm not just talking about antibiotics, remember that. And COVID has awfully taught us that even the wrong use of antifungals has given us a huge rise in the cases of mucormycosis. So it's overall injudicious use of antimicrobials which have led to this kind of a scenario. So we need to monitor this to preserve their effectiveness, and that is what we know as the antimicrobial stewardship is. And it's a coordinated effort. This needs to be a coordinated effort. This is not one man's and the most important part of the story is that we need antimicrobial stewardship is to improve the patient care. And of course, we need to really look at the outcome betterment. So there has to be a collateral, I would say, partnership to reduce down the collateral damage by reducing down the antimicrobial use. So what are the core elements and what the healthcare systems are doing, what the Department of Family Health and Welfare is doing, what ICMR is doing, especially in India. Now, this is the data from the CDC where they are suggesting that these are the core elements of any antimicrobial stewardship programs are. And what are those? There need to be the national plans and strategies. There have to be a regulation and guidances. There has to be an awareness, education, not only in the healthcare providers, but also all the parallel systems, including the public awareness. There you can use freely the print and the social media, as well as the electronic media. And of course, we need to have supporting technologies for the data. And then, of course, when you execute them, there has to be a leadership commitment like IMA is doing, that there is a leadership commitment. There has to be an accountability and responsibility, not only of the organizations, not only of the government, but also individuals. And remember that for that, you need to have a robust monitoring, surveillance, and reporting back and feedback. So it is extremely important for all of us. And that's what, exactly WHO has suggested in their AWARE program. AWARE stands for Access, Watch, and Reserve. WHO in 2017 introduced this AWARE classification for the in the antibiotic for the essential use list. And it's a tool for the antibiotic stewardship, not only for the local, but also for the national and the global levels. And an emphasis was given on the importance of the optimal use and the potential antimicrobial resistance. So it had three aspects: access, it should be available. Yes, it should be accessible. But remember that there has to be a vigilance. So you need to watch and must be used very sparingly and reserve it only as a last resort whenever it is necessary. This is what the AWARE program was. And as far as ICMR is concerned and the health ministry is concerned, I'm very proud to say that even 2021, they came out with the beautiful guidelines. And what are the strategic approaches that ICMR has suggested? Again, the same thing: appropriate antimicrobial therapy, as Ketan has talked, optimal antimicrobial prophylaxis, development and implementing the antibiotic policies and the standard treatment guidelines, prospective auditing, and providing feedback with timely intervention. This is one of the most important things, and probably we need to really improve on that. And also we need to also improve on formulary restriction and pre-authorization. And that will genuinely improve the education and administrative challenges. And this is what the antimicrobial resistance surveillance and the research network of ICMR is doing. They are generating the relevant evidence. There are national representatives to gather the reliable data, and then the information is collated. And there are 6 nodal centers and 16 regional centers all over the India, which are active. In Mumbai also, we have got 2 centers, which are regional centers at Hinduja and also at the Sion Hospital. And the nodal centers are at PGI Chandigarh, at AIMS Delhi, at Jipmer Pondicherry, and CMC Vellore, and they are doing amazing job. Dr. V. Balaji was there in one of the conferences where Dr. Agam and Dr. Ketan arranged, we organized under the banner of academy, and it was really intriguing to find out that yes, the people are putting the efforts. And this was what the ICMR's January 2020 to December 2020 report that they have submitted. And what they talked about the antimicrobial stewardship is the infection control, the appropriate use of microbiology lab, the streamlining and de-escalation. Now, this is what Agam was talking about, that if at all you have started a broad spectrum really antibiotic or a powerful antibiotic, if you really find out after the culture reports that the drug is not necessary, always remember that be prepared and also be willing to de-escalate the therapies, especially in a scenario where there is possibly a better and more sensitive antibiotic data is available. Switch from parenteral to oral therapy, how beautiful it has to be done and how well it can be done. They have talked about it. Then of course the formulary restriction that I was talking about, and for the pre-authorization, and of course the feedbacks and auditing with the intervention. And of course 4 Ds: right drug, right dose, dosing interval, and right duration that Ketan has talked about. And there are a few other strategies like going to the peripheries, even training the staff nurses or AYA workers, or even at the pharmacy level, stop discouraging the prescription of or the dispensing of antibiotics. All those things they are working, but still we are understanding that there are some gaps which are needed to be filled. Like probably we need to have more local regional antibiotic sensitivity data. There is lack of reliable community acquired data as well. So we need to have a national antibiogram available. So API, along with one of the pharma companies, they came out with an Arise against antimicrobial resistance initiative, where we have now almost around 100,000 specimen data of pus, urine, and sputum. And we do have what nearly data from 16 different states of India. And we have not only have the different data, but also we do have what the specific organ, I would say microbe specific and the antibiotic specific data which is available. So remember that this probably is one of the solutions of creating a community-based antimicrobial or antimicrogram for the doctors, and that will surely help people to take a very informed decision. How it will be easy for you that on your mobile or on your laptop or a desktop, you just visit the site and find out what is the bug which is commonly seen, what is the respiratory tract challenge causing a bug, or a urinary tract challenge causing a bug in your community, and you can choose the antibiotic according to the available data. That will be very easy. And that's how really WHO is trying to recommend that doctors, patient, healthcare industry, policymakers, Indian regulators, and even agriculture sector needs to join hands together. And as healthcare providers, we need to really practice the basic prevention control policies of hygiene, proper instrumentation, and protecting the environment. Only prescribe and dispense antibiotics when they are needed according to the current guidelines. Report the antibiotic resistance immediately. So we need to have the pharmacovigilance also equally effective, and the reporting of resistance is also equally important. Talk to your patients about how important it is not to take antibiotics correctly. We all know that, and especially being the primary care physicians, you all are under immense peer pressure directly from the patients, because most of the patients are Google doctors or the social media doctors. They'll come out with some kind of weird demands whenever they enter in your clinic. So be prepared to answer these difficult questions, and also talk about the importance of stopping the misuse of antibiotics. And all the patients need to be told about this. Tell them that it is not proper to demand antibiotics if your doctor says do not take it. Always follow your doctor's advice when you go and use antibiotics. Never ever use the go to the chemist counter and purchase the antibiotics. Also, do not share or ever use the leftover antibiotics. That can be a big challenge. And of course, the importance of vaccination has to be adequately implemented. For the policymaker, we need to ensure the robust national action plan, which slowly we are doing. We need to invest a lot in our healthcare budget to improve all these challenges. We need to improve our surveillance. We need to strengthen our policies, programs, and not only strengthen them, but implement them more effectively with a proper audit and the regulation which is happening, and make the information available on public domains, so that even the healthcare industry, the pharma industry also takes a close note of it. And to the agriculture and animal husbandry people, they need to understand that please use antibiotics to animals under the veterinary supervision, not to use antibiotics for the growth promotion or to prevent diseases in the healthy animals. Vaccinate animals to reduce down the need for antibiotics. Promote and apply good practices at all the steps of production and processing of the food in the animal and the plant sources, and improve the biosecurity on the farms and prevent infection through improved hygiene and animal welfare program. Of course, we do have got non-antibiotic targets, target specific therapies slowly coming up. Like Agam has talked about vaccines, there are some immunotherapies, there are phage therapies which are coming up. We are also talking about the gut microbiota transplantation, the stem cell transplantation. But remember that they are still at the horizon. They need to see the sunlight of the day. Till the time, as Agam has made to pledge, let us all pledge to stop overuse and misuse of antibiotics. Remember that antibiotics is the only group of one of the drugs where wrong use in your case can impact the outcome in your dear one, in your close one, in your friend, or the patients, those who are known to you. So let us all arise against this antimicrobial misuse, and let us understand the importance of stewardship as far as the antibiotics are concerned, because every antibiotic class is a limited resource and pipeline is drying very, very fast. We do not see any proper antibiotic coming again, in couple of decades from now. So use appropriate guidelines, and guidelines, as Ketan has talked, can be very, very effective only when they are implemented. And implementations do not work unless the local commitment and educational outreach is there. And I thank IMA for this educational outreach. So friends, if you don't want to have the life which is on your left of the screen, try to be right on the right side. Thank you very much for this beautiful opportunity. I once again, express my gratitude, my thanks to the entire IMA team, and of course, the today's sponsors and all of the friends, those who have spared their afternoons to join with us. Thank you very much. Over to you, Ketan. Ketan, are you around?
I think Ketan is not there. So by the time he joins,
Yeah.
Mangesh, what do you think? What can be done at an individual level? See, I understood your antibiotic stewardship program and the message that you're trying to convey. But for the benefit of delegates, like a family physician, what can he do at his individual level to contribute to this
Yeah,
antibiotic
so as you have
resistance
also
menace?
pointed out, Agam, very well, that we need to be really choosy when you are choosing antibiotics, and if at all, you need to answer, at least ask yourself that whether you genuinely need the antibiotic or not, whether you genuinely need a prescription of an antibiotic or not. Is this a clinical scenario where you need to really use antibiotic? And if at all you need to use antibiotic, probably what is the best possible antibiotic that you are needing. That is one of the greatest area where we all have to improve, not everyone, almost all of us have to improve. Right, Ketan, I joined back. Okay, fine, thank you.
Yeah, hi, sorry. So it was a fantastic presentation, and we had obviously a very good overview what we had from Dr. Mangesh. So now I will invite Dr. Kunal from GSK. He would be taking a question answer session. A lot of questions, I'm sure, which has been already flooded over here. And this topic, which is absolutely of utmost importance, be it at any level, in any specialty, and whosoever, whether is a just recently joined a resident doctor or a practicing senior practitioner for many years, still it is very much pertinent. So Dr. Kunal will take the questions, and Mangesh, Agam, and myself will try to sort out most of the questions, whatever is there. So Kunal, it's all yours.
First of all, thank you so much for inviting me. It's my... Yep. So first, yeah, I hope that I am audible. Yeah. So thank you so much for giving me this opportunity in terms of moderation. I am Dr. Kunal Dalal, anti-infective TA lead from GSK. First, actually, I would like to thank IMA for organizing this event in Antimicrobial Awareness Week and giving opportunity to GSK for taking this particular session. It's a fantastic that we've been a patient-centric organization doing left and right many different initiatives, and one of the very, very important initiatives, and we always in forefront of doing all these patient centricity activities. Before going ahead, first of all, I would like to thank Dr. Ketan Mehta, Dr. Agam Vora, and Dr. Mangesh Tiwaskar sir for taking fantastic session. It's been like, you touched upon almost all the areas, be it like the OPD era or be it the inpatient, and mainly in terms of the antimicrobial stewardship, what all the things are currently happening in India, and what all the things, in a way, there is an unmet need, and what all different parameters that we could bring in to maximize, I would say, our potential in terms of reducing the antimicrobial resistance. So without further ado, actually, I would request audience also to put the question in the chat box. I can see the chat box here, and I'll just see what all the questions that has been come up by you. I'll take few questions from them, and of course few questions that has already been popped up by the audience. So for that, actually, let me first take one question to Dr. Ketan sir. Sir, you have highlighted the certain important principles, but a lot of people, they've been asking the same question again and again, like what are the important principles that someone has to inculcate for a rational usage of antibiotic in their OPD based practice. So like any patient comes to me, what are the important principles or the steps that I do need to see before selecting antibiotic, or probably not selecting antibiotic?
Kunal, in fact, that is what I had summarized in my presentation. So if I have to start,
Sorry to,
we can start.
Ketan, sorry to interrupt, but you are not visible. I am head office camera is probably some challenge. You are not visible to us.
Okay.
Okay. Can I go over there?
I think you are audible, so you can continue by the time you fix up the technical glitch.
Okay. So, of course, they're trying to fix the issue. So now the point is, of course, if I have to summarize, the very important point is, if you just recollect my final 20 questions, first of all, does this really an infective? Somebody who is obviously you are going to prescribe antibiotic. The question which you are going to ask, is this a fever which is due to infectious cause? Because if it is a non-infectious cause, there are so many non-infectious causes of fever which does not require antimicrobial agent. So that is one important thing. So first, yes, if it is a infective, yes. Second, when you'll ask, are you thinking in terms of a bacterial infection or non-bacterial infection? Again, this will come with your experience over a period of time. If it is a non-bacterial infection, especially if you are thinking of common upper respiratory tract infection or a loose watery diarrhea in a pediatric age group, these are all common viral infections where you don't require to give antibacterial agents. So you need to be very clear, even if it is infective, it is a non-bacterial, you don't need to prescribe it. If it is a bacterial infection, if you suspect it strongly, then you need to learn what could be the likely organisms. Are we dealing with gram positive? Are we dealing with gram negative? Or are we dealing with anaerobes? When we think of, say, for example, upper respiratory tract infections, it is for all practical purpose, we have to take it, it is a gram positive, and gram positive organisms. When we think of a community acquired type urinary tract infections, it is always a gram negative, and gram negative infections. So we need to be very clear on choosing that what sort of organisms are we looking at it, even if we know it's a bacterial organism. Then next would be, okay, which will be the drug best suited for this infection. So in which you will have still a variety, a big basket of antibiotics available to use. You need to choose the one which is the most narrow spectrum where you think it is going to work. You don't have to start with a broad spectrum antibiotic when you know it's a clear-cut respiratory tract infection. You need to use those agents which will be useful in that. Now, again, when you have selected that, you need to select the right dosage. You know, there are certain drugs which you need to use it as per your body weight. And you cannot use the drug which is just a standard protocol. Say, for example, you know, ofloxacin, which is available as 200, 300, 400 milligram also. So it is not that for everybody the standard dose is 200 milligram twice daily. You need to use it according to that. Next would be giving the right frequency of the dosage. That is what is very important. The duration of the dosage which you need to require, because somebody who has got a mild infections, you may require only for 5 days, but somebody who has got a moderate to severe infection may require for 10 to 14 days. So again, the duration of therapy will be depend on how the patient is responding. Next, whether you need to get it supported by microbiology. So in that case, appropriate cultures need to be sent. If you have got a culture results, then if you need to escalate or de-escalate. Now both these are very important. At certain situation, you need to escalate when the patient is not improving with your antibiotic which you have given, or if the patient is improving but your culture sensitivity shows that now this patient has got definitely even a spectrum which can be covered with even a lower down antibiotic, you can easily de-escalate also. So all this would be formulating the rational use of antibiotic in right clinical situation. Thank you.
Thank you so much, sir, for giving such a wonderful narration. So next question to Dr. Agam Vora, sir. Sir, are you there? Dr. Vora?
Yes, I'm here.
Yeah. Hey, hi, sir. Sir, so there are two questions, very, very interesting question from the audience. So number one is that they are saying that we are following the antimicrobial prescribing rules, but what has been happening when the patient come to us, they must have taken some XYZ antibiotic and then come to us, right? So how will we follow the AMR practice here? The second question is that like many Ayush doctors are there also, they've been prescribing left and right over-the-counter antibiotics. So how that we deal with all these issues? Because I think these are the very practical things that what they are asking probably, and that also increases the AMR. So could you please address, sir, this issue?
Yes, thanks for that question. These are real day-to-day problems. Now, there is very easy availability of antibiotics, and a lot of patients would use antibiotics that they have used in past for the recent infection as well, and that would create complication. I think detailed history taking is the only answer. If you really dig into the history, you will get the clue about it. Especially they would visit you since the antibiotic has not worked, and that would make it a little easier for you to choose antibiotic for this infection. If you are in doubt, there are a lot of newer tests available which would help you suspect infection, as bugs have very beautifully divided system. So if you have respiratory infection, it is going to be gram positive infection. If it is urinary tract infection, it's going to be gram negative infection. If it is skin and soft tissue infection, it's going to be gram positive infection. You can collect cultures from the various sites if you have access to, or if you feel patient is probably has a systemic infection, you can collect blood for cultures, and it would be it would give you clue in next 2 to 3 days time. During that time, you can cover up for the antibiotic which you feel would take care of the infection that is in mind. To say respiratory tract infections, you would choose penicillin with ESBL inhibitor, or you may use a second generation cephalosporin. That would be all that is required. For urinary tract infection, again, you would choose second or third generation cephalosporin because it is going to be gram negative and you will have to cover for that, waiting for culture reports. There are quicker tests available. Say you have a high risk patient of uncontrolled diabetes, a patient is a case of renal failure or liver transplant, etc., etc. In that situation, please put all your efforts to find out the etiological bug. You have now spot urine antigen test available. You have multiplex PCRs available. Though these investigations are costly, but trust me, they are going to be really fruitful in deciding your line of treatment. Thank you.
Yeah, thank you. Thank you so much, sir. Now, I'll go to Dr. Mangesh Tiwaskar, sir. Sir, one point that you highlighted in your presentation is very, very, I would say, relevant, which is susceptibility data. So, sir, when we see currently in this era, in vitro susceptibility data, when it comes to especially community-acquired infection, it's very sporadic, very limited. I know probably different institutes and even the ICMR and national institutes, they are also tying up and then developing the data. But as of now, there is a very scarcity, very limited data it's available, right? So can you elaborate some light on it, sir? Like, for example, if you're working currently, how exactly that's, or how far that we have reached in terms of developing that registry pool, and when it will be available for the probably the GPs and CPs and all, then they can, start practicing evidence-based medicine, sir.
Yeah, it's a good question, Kunal, but it's again a difficult area to address. Honestly speaking, we have started taking some baby steps. These are all initiations that we have done, and primarily an initiative of one of the pharma companies, and then we have joined hands together with them to improve on that. And most importantly, to understand is that this is a dynamic area, because the cultures, the sensitivities, they keep on changing. So it needs a continuous process. It's a continuous process, and it will call and demand for a lot of commitment and also a lot of investment. So all those things needed to be addressed. Of course, this is a start. Over a period of time, we are more than sure about it that we will definitely develop it. But if you really look at, why we use so much of empiric therapy, have you ever even you ask that question to yourself, you'll always realize that there are situations where you need a genuinely prompt antibiotic therapy, like probably you have a life or a limb threatening infection, or as Agam was talking about, that you delay the antibiotic initiation and the mortality increases immediately. Yes, you do need antibiotics there, and probably you cannot wait for the cultures and all that. But what is the most difficult aspect of the story is this, that most of the cultures, especially on the OPD infections we have, they do not provide you the genuine, I would say, results that you expect from the microbiologist or pathologist. Now that is a challenge, and quite a few times negative cultures, especially pneumonias or sinusitis and all that, also do not tell us about the possible offendants. But remember that the most important is the reason for the empiric therapy is our provider's belief. And a lot of us believe that there can be a fear of error or missing on something, or we do not believe on the culture data, which is fairly okay. Definitely, we all probably have sailed in the same boat at some point or the other, that we thought that antibiotic use, especially in the probably viral infection scenario, will prevent the secondary bacterial infections, or the patient is genuinely sick, you should give more antibiotics, or the myth of combination of two antibiotics for gram negatives and gram positives like pseudomonas, or probably, somebody has taught you that drug X or Y or Z is better. All these things ultimately led to this scenario. And as Agam was talking about, I have that slide with me. I'm trying to locate out where that slide was, just for the benefit of all those, those who have joined here today in the afternoon, just how beautifully. And this is also, again, let me very honest to you, this was the Agam's concept. I'll try to share my screen again here to just people, know what exactly it looks like. So give me a minute. I have located the
Sure.
slide just now, and I'll show you
Sure.
that slide. Look at this. I hope you're able to see that. How
Yes,
these
sir.
bugs, they really beautifully distribute themselves. Now, this is what the oral infections, the skin and soft tissue infections, the joints, the abdomens, the urinary tracts, the respiratory tracts, and the meninges. Now, if you really closely look at this group of the drugs, which is usually the respiratory tract, both upper and lower respiratory tract, community as well as hospital, majority are gram positive bugs. Now, why it is important to understand? Because that gives you a choice. The spectrum immediately narrows down. The confusion starts running away as far as the choice of the therapy is concerned. Look at the abdomen, look at the urinary tract, look at the meninges. These are all mostly gram negative bugs. So you can use, preferably you can initiate at least with the gram negative covering antibiotics, so which are available. So that also has narrowed down your search. And also, if you really look at the skin and soft tissue infections and bones and joints, you can always see that, these are all the important things that, so if we practice this, right, it will be little easier for us to choose antibiotics and to narrow down the spectrum of choices also. That is most important.
Thank you so much, sir, for a detailed answer. So now actually two questions that I'm picking up, and specific for the pneumonia. So I am actually throwing this question to Dr. Agam Vora, sir, again. So number one question is role of procalcitonin in management of community-acquired pneumonia, and the second question that is asked, it's like, in adult with community-acquired pneumonia who test for positive for influenza, probably it's very much relevant in this scenario, then should the treatment regimen include antiviral therapy as well? So number one, role of procalcitonin, and if pneumonia with viral influenza, then what would be the line of management?
I must thank you for this question. Who has asked this question? Do you have access to those questions?
Yeah, I am having it. 1 minute, let me read the name. 1 second. Dr. Naresh.
Hi, Dr. Naresh. Thank you. I wanted this question to be there. Role of procalcitonin. Procalcitonin usually is not required for your community-acquired infections when you're treating it on OPD basis. But yes, when you have sepsis or when patient presents with multi-organ dysfunction syndromes, you would ask for procalcitonin in hospital settings. So for OPD, no role. For ICUs, yes. Now, more than single value of procalcitonin, it would be the rising titers of procalcitonin, which would be more relevant. So it's not only day 1 procalcitonin, it would be day 3 procalcitonin, which will give you more information, and it would guide you to whether patient is going into this sepsis, multi-organ dysfunctions, or patient is improving with the choice of treatment. So that is about procalcitonin. And second question was about influenza. Now, influenza, yes. If you clinically feel it is influenza, and if you've got answer that influenza positive, and if you get chance to treat this patient in first 2 or 3 days, yes, you can definitely put them on antiviral therapies. But if patient comes to you little late, or most of the time patient present to you with secondary bacterial infection. So whenever it is influenza, very commonly it gets infected with streptococci, and patient presentation is not for the earlier viral, but now for the secondary bacterial infection that is got. And in that situation, antiviral may not work. So you may have to choose your patient profile one. You may have to choose during what time patient presents to you, and whether the presentation is due to this virus or it is due to secondary infection. If given early, antivirals work well. True for even COVID infections. If you give it little late, it does not work. Thank you.
Yeah, thank you so much, sir. Then one question actually from many of us, even I am also having that question in my mind, because we do have antimicrobial stewardship principles, criteria, implementation, even Dr. Mangesh to you, and to probably to all speakers, right? But all these things that has been there on page theory and all the hospitals, they have implemented beautifully. Like for example, multidisciplinary team, it is required, microbiogram, it is required, role of the pharmacy, role of the other department as well. But when it comes to the GP and CP, right, they'll have to implement certain thing out of this antimicrobial stewardship program. So how do they customize, or what are the important parameters that they need to inculcate in their practice to give some sort of relevance to antimicrobial stewardship program, whatever it is there in the hospital? So at individual or the trade doctor, what are the things that they have to follow, which is there on as a part of the AMS, antimicrobial stewardship program, that is established in the hospital? Anyone can take it, Dr. Mangesh, Dr. Ketan, sir.
Yeah. So shall I, Ketan, with your permission?
Yeah. Yes, of course.
you.
Stewardship, it is your baby.
So, okay, so I understand your challenge, and most of us, not only why primary care people, we all also, to be very honest to you, that yes, we keep on doing, but what there are certain criteria that you can always look in. First and foremost is my request to each and every of my friend, those who have joined today in the afternoon, that please understand that, think about the most common causes, because they are the most common things which are happening. So do not try to think about rare possibilities or rare challenges. And also, again, the importance of a proper examination, proper good history taking, even knowing about the previous comorbidities, probably possible associated risk factors, available clinical parameters. It's not necessary that somebody walks into your clinic with the history of fever, need not be specifically written with an antibiotic on day one at the first point of contact. It's not necessarily important at all. What is most important is probably you may give patient a symptomatic relief, talk to them about what is your plan, at least that you can do, tell them that why I am not put you on with antibiotic. Most importantly, where we fail, in our I would say commitment, is that we fail to communicate what we are thinking, and we fail to tell patients that I am not starting you on an antibiotic right now because of these reasons. And then you can ask for the basic tests, you can ask for a CBC, you can ask for a urine examination, maybe possibly the related investigations you can ask, and then probably think about adding additional antibiotic depending on two. Number one is that will give you 2 or 3 chances. Number one is this, that the patient will come back to you with the reports, will tell you, give an opportunity to reassess the patient completely, find out whether the patient is improving or patient is deteriorating, and then you can choose whether to give antibiotic or not. So at least, even though we do not understand probably the different antibiotics so precisely, or you do not understand which is the antibiotic for a gram negative bug or a gram positive bug, you may not remember it as well. But at least remember that these are the areas where you can genuinely start and delay the initiation, especially in the OPD practice. I'm not talking about the hospital practice, in hospital practice. I'm talking about the genuine OPD practice, where you will definitely get a chance to investigate this patient and justify yourself whether you genuinely need an antibiotic in this patient.
Thank you so much, sir. Anything, sir, would you like to add?
No, Mangesh has rightly pointed out, there are another couple of points which we would like to focus from a family physician point of view. Antibiotic is not just a one blanket therapy which you can give it for any infection. So it's not like, chalo aaj roti ki jagah hum bakri de dete hai ya thepla de sakte. So it is like you need to give specific thing for a specific problem. So that is where you need to have a concept clear on that. And as Mangesh has said, that one, we really need to do whether this person requires antibiotic or not. If you can wait for starting antibiotic, that is another thing. And then if you are starting it, start the right one. That is most important. Thank you.
Thank you, sir.
Kunal, I have just for the help of people, those who have joined, and this is another, I would say, thing I wanted to show people. It is just a ease of understanding, and that's what
Please, sir, go ahead.
trying to explain. How do you choose actually these antibiotics are like, and as I am sitting at home, I have opportunity to share these things with most of the people there. I believe my screen is visible.
Yes, sir, it is.
Yeah. So now you can see that upper respiratory tract infection, the commonest antibiotics that you can choose from are macrolides, penicillins, fluoroquinolones, and first generation cephalosporins. But quinolones, now we do not promote, especially in the routine But these are all the basic, mostly the gram positive bug covering antibiotics. You look at the urinary tract, which will be gram negative, more of newer penicillins or aminopenicillins. Again, here you can go, little higher generation of cephalosporins, like third or fourth generation cephalosporin or aminoglycosides. These are the drugs of choices. For again the abdominal infections, again the same choice, because they are again mostly the gram negative bugs which are responsible. For the lower respiratory tract infection, you can come back to again the gram positive choices, and this is what you can choose for. For the mouth, for the skin and soft tissue, mostly there is a mixed infection. So along with the both gram positive gram negative cover, you can think about adding a metronidazole or an treatment for anaerobes as well. So these are all the choices that you have. It's not too difficult as probably it sounds. Unfortunately, we consultants have made life of primary care people more confused and more difficult, and it should have been our responsibility to really come out with the simplified ideas of dissipating knowledge about the right choice of antibiotics. What do you say, Agam?
No, I agree. I like this idea of looking at the bugs depending on the system involved. One has to look at which system is involved. Unless you suspect a bug, you cannot treat.
Yeah,
So one must try to find out which system is involved. Try to find out whether it is a bacterial infection, because many a times it may be a non-bacterial infection, and many a times it may be, your malaria, you may have to choose your antibiotics accordingly. Once you have identified the system, look at the probable bug, whether it is gram positive, gram negative, or typical, and then initiate your antibiotic choice. Completely agree.
Thank you so much, sir. Dr. Vora, sir, one of the question actually someone has asked about the MDR TB. So of course, sir, you have to take it up.
Eesh. MDR
I
TB.
think if
So
I interf-
they have written it's about the management of MDR
yeah,
TB.
I
So,
think
My only one request.
so that
yeah,
would
we
be
will-
probably half an
we
hour,
will
sir.
we will restrict it to predominantly rather than going into anti-tuberculosis, because that's a bit Pandora's box.
No.
And
Allow me to
That will open up.
allow me to answer this question, because
I know it
MDR
is your
tuberculosis,
love.
He'll be more than happy to take.
nobody can spare themselves from not
From TB.
knowing tuberculosis.
Absolutely.
Be it whatever practice, be it a gynec practice, be it a
Absolutely.
neurology practice, be it a diabetology practice, one must know about
Absolutely.
tuberculosis. And I would request you to spend adequate time on diagnosing MDR tuberculosis. MDR tuberculosis is not a clinical diagnosis, it's only a microbiological diagnosis. Do send your sputums, do send your whichever tissue for gene expert. The minute you send it for gene expert, same day you will get answer about rifampicin sensitivity or rifampicin resistance. Once you have documented rifampicin resistant, treat it as a drug resistant TB, that is MDR TB. If it is rifampicin sensitive, send it for first line LPA. LPA will tell you about INH resistance also. If it is INH and rifampicin, it is called multi-drug resistant. If it is only INH resistant, it is called mono-resistant. And if it is only rifampicin, it is to be treated as multi-drug resistant. So I think as a family physician or as a non-chest or non-TB specialist, I would want you to diagnose tuberculosis, and I would want to differentiate MDR from non-MDR tuberculosis. All drug-sensitive tuberculosis to be treated by you. Everybody must treat non-drug resistant tuberculosis, but when it comes to drug resistance, please leave that to me. Me in the sense, please leave it for chest physicians or the TB specialists. Please don't treat them. Thank you very much.
Thank
I
you,
cannot
sir.
agree more than what you say, Agam.
So we are actually going beyond our time. So last question that I'll take it up and for all the speakers. So since that we discussed so many things, I just would like each and every speaker to give very short summary, or I would say 3 to 4 points they really want to send the message to the audience today, and when they go out of this hall or out of this this webinar, they'll kind of keep in their mind all these key and important messages while they treat this group of the patient. One by one, sir.
Yeah,
Over to you, sir.
correct. So very important point is antibiotic usage should be adequately and wisely used. Remember one thing, presence of fever does not mean there is a lack of antibiotic or it is an antibiotic deficiency state where you need to start pumping in antibiotic in the body. So that one thing is very, very important. which all of you should keep it in mind. So it is not just important to understand that when to use antibiotic, but it is more important to understand and realize when not to use antibiotic.
Agree.
So that's one. Another point would be whenever you are using antibiotic, please use the right selection, right dose, frequency, and right duration. And that would really give a good, adequate response for the patients. Thank you.
Thank you, sir. Dr. Vora and Dr. Mangesh, sir.
Mangesh first,
Uh,
seniors first.
I know that, Badmash. So anyway, my message for is this, that even though I spoke about the components of the stewardship, I am more than convinced myself that as it may sound difficult, but it is not as difficult as it sounds. There are very few things, if you really implement very aggressively, you may probably not reach a stage where you or the patients will need an antibiotic immediately for the immediate diseases or community acquired disease. Number one is this, that follow the basic infection protocol very meticulously, like hand hygiene, food and water hygiene, that we always keep on talking about. But most important is effective implementation of the vaccine protocols for all the vaccine preventable diseases will definitely minimize the injudicious use of antimicrobials at all the levels of clinical practice. So important is that. And as Ketan has really pointed out beautifully well, that all the newer antibiotics or better sounding antibiotics need not be the great antibiotics. There is no ideal antibiotic which is ideal for all the possible situations. So you need to use your common sense, your clinical sense, and most importantly, your local microbial data to prescribe antibiotic very clearly, differ from the suggestions and Googles and all that. People are going to come to you with Google questions, Google or WhatsApp chats or something like that. But you need to be smart enough to deal with such kind of patients. I keep on doing every day, and I in fact enjoy their company sometimes, because that makes my life more easy, because they are the people, those who also understand a little bit better about the science, those who are come Google read to you. And of course, as far as the use of routine antibiotics in your practice is concerned, remember that there is only one thing I can tell you is this: it is your discretion to really prescribe. So unless and you are convinced about the smart use, do not use it. Thank you.
Thank you, sir. Yeah, Dr. Vora, sir. Yeah.
Yep. Before I give you my final message, I must thank Ketan for conceptualizing such a nice program, and I must thank Mangesh for the excellent presentation. And a lot of slides that I used, I actually borrowed it from Mangesh, so I used this platform to thank him for that as well. I must thank GSK for coming out with this, partnering this particular initiative, because without your support, it becomes very difficult for us to organize such program. And of course, my home ground, that is IMA, for giving me these opportunities. I can see that 100+ doctors have logged in from out of Mumbai, and I'm so happy that we are now reaching out to our horizons are probably crossing my area of practice, and thanks that I got so popular. The credit goes to Mangesh, Ketan, and IMA.
No, I'm very jealous because you are getting so much of appreciation, and मेरे पेट में बहुत ज्यादा दर्द हो रहा है, और हमें सब वैसे भी अपने को बहुत ज्यादा पेट दर्द की बीमारी सभी को होती है.
Don't take antibiotics, sir. I would conclude my, I would give you my take-home message as the future of antibiotics depends on you and me. We cannot misuse antibiotics anymore, because to fight drug resistance, if you don't take any action today, there'll be no cure tomorrow. It is not only for anybody else, but it is for our own future generation. The antibiotic resistance.
I think Agam's internet connectivity has lost. So I'll just complete what he wants to say. Is that, if at all you need to prevent the future antibiotic resistance, and probably, in a scenario of bad bugs and no drugs, if you don't want to land, or if you don't want all of us to hand over a very bad challenge to the future generation. Maybe possibly this is the time to improve. Over to you, Kunal.
Yeah, thank you so much, sir. I would like to thank one more time to Dr. Ketan, Dr. Mangesh, and Dr. Agam Vora. Sir touched upon all the aspects of antimicrobial resistance. Very important message that we are driven today. What would do need to take care, if we want to preserve the antibiotics for the future. Otherwise, we'll be left with no antibiotics, even if it is smallest of smallest infection. So thank you so much for giving us opportunity, and GSK being patient-centric organization, we have the same objective what IMA has in terms of driving message in terms of we want to also drive keeping in mind that if there is no need of antibiotic, we should not take it as well. So with this, I would like to hand over to Dr. Ketan sir for completion of this event. Thank you, sir.
Yeah, thank you, Kunal, for conducting the panel discussion so well. And any good thing comes to an end. So, to conduct a final vote of thanks, may I invite Dr. Jayesh Lele, this is the conceptualization of the entire project was none other than our own trust board member and honorary general secretary of IMA headquarters. So I invite Dr. Lele sir. Of course, he has been so actively working with so many projects at multiple levels. I wonder how he's working, and the energy and enthusiasm which he delivers. I think IMA Mumbai West is really blessed to have a person like him. Over to you, sir. Thank you.
Thank you, Ketan, for very kind words. First of all, let me thank the entire GSK team. Of course, Avinash, I am working for almost more than 4 or 5 years, and every project which Avinash brings, I am aware that how to go about it, and we are handling. Maybe it's a fever clinic, or now with the antimicrobial, this is, I think, a 4th year we are doing it. Thank you, my friends from my branch, Dr. Ketan, Agam, Mangesh Tevaskar, for these 2 days. At this point, let me thank all the states who have done this program, because 12 states have completed the program. Another 7-8 states are remaining. And looking at that, in fact, we had only 18 in mind to do that, Avinash. But then some states which have asked for it, so I am going to give those states also. Let's do it another 4-5 days program. I will take the opportunity to take your permission and Avinash to control, because those states were small, but even then they have asked for it, so we will do it. We'll from our side, we will see that the entire logistic support is given to them. Let me thank the entire GSK team for doing this program, and this 1 week is there. In fact, I was interviewed about 1 month back, and Avinash saw that interview on the TV also, and that time mentioned that we are going to have such kind of activity, and 1 week will be concluding on the 22nd November. Some programs which are left out will do it in another week's time. And so today I took this opportunity to thank the IMA Mumbai West for my parent branch, Dr. Saurabh, who is the president, and I am very happy that the president-elect, who will be installed at the Mastacon, Dr. Suhas Pingle, also his presence in the entire program. So we close this and we'll put it entire program, all the 8 slides as well as the all the recordings will be put into our IMA headquarters, CME current venues which we are putting it, and then anybody can use it and download and see the programs. It will go a long way of that. So we close this and we will request everybody to join for a group photo. Avinash, please come in front. And really it's a great opportunity for me to conduct and advise this program, which was launched in Guwahati some time back. Avinash couldn't attend that time, but we have launched it and we have started that. Fever clinic is going on, Avinash, and just I had a talk with Sanjeev in the morning, and the vaccine program also is going on. So really that's 3 places GSK is working with us. So it's a really very happy to have their support. Thank you. ये बंद करते हैं. Everton? How do you have the banner? चालू करो ना, banner चाहिए ना. Get the banner. Banner is getting covered. Yeah. Come. Make full screen. I wanted this GSK banner to come.
GSK is your no.
Yeah. No, not this one, it's a different. Yeah. Ketan, take in one photo, phone also will, so that we'll put it on the, immediately on the website. Please join for tea in the boardroom. Take on the phone. सब GSK is there. Thank you. Kunal, Delhi also appreciated because that day we conducted in Delhi also. Dr. Saini was there, Dr. Ajay Gupta was there. Please join in the boardroom. Sure. Yeah. इधर मेरा प्रॉब्लम
Two things. One is here. One light here for the face for you, and one light here for panels.
जरूर.
I told Seema also I'm telling you.
We'll get it done.
Otherwise, external light.
Yeah.
Come on. अभी sanity coil. Sanity coil screen पे है. हाँ? हाँ, sanity coil मैंने
फ्राइडे को मेरा है
हाँ?
फ्राइडे को मेरा है
हाँ, एक screen डालूंगा.